Hi, this is Dr. Gregory Doerr for Functional Soft Tissue, and today, or this month's, April's condition of the month is going to be sacroiliac joint rotational problems. Now, what we're looking at is laxities or slight instabilities, but not true instabilities, ones that need to be surgically corrected. So what we're going to be doing is starting with the evaluation, the history and diagnosis associated with sacroiliac joint dysfunction. And some of the things that are very common associated in the history is these are going to be patients that have problems with changes of position. So getting in and out of a chair, in and out of the car, twisting in bed. Activities like that tend to aggravate the sacroiliac joint when there's some kind of a laxity going on or irritation. So we look for those in the history. If you have more of the athletic population, you may notice that they feel worse doing hill workouts, running uphill or downhill, up and down stairs. Things along those lines are also provocative to the SI joint. But these are things that will show up on our history. What we're going to do now is evaluation-wise, and we're going to show some more unique evaluations associated with SI joint dysfunction, and we're going to start with the supine to sit evaluation. Now, the supine to sit evaluation, what we're looking for is rotation associated with the pelvic joint, the SI joint. And when we come to a flexed posture, whether it's at the hip or the lumbar spine, the natural rotation associated with the pelvis is posterior rotation. So when that happens, we're going to have the acetabulum raise up. If we have a posterior ilium already at the sacroiliac joint, that acetabulum is already going to be in an anterior superior position, giving the appearance of a short leg. So when we come to a flexed posture from the supine to sit position, we should notice that the short leg will get longer associated with a posterior rotated ilium. The reason that is there's not a lot of rotation that happens at the SI joint, only a few degrees. So if we already have one that's locked posteriorly, or I shouldn't say locked, that is in a posterior position, when that person comes to a flexed posture, that posterior rotation isn't going further back. However, what we normally have is a posterior rotation on one side. What we'll have is a compensation an anterior side on the opposite. So as this person comes to that flexed posture, this one's already back, so when she flexes, it's not going more back. However, the anterior side is going to be rotating more posteriorly, raising up the acetabulum, shortening this leg, giving the appearance that the posterior side is getting longer. So our patient we're going to look at, we're going to start in that supine to sit position, and we're going to have our patient come up to a seated position on a count of 3. So what I'm doing with my hands is I'm just letting them rest right at the top of the malleolus. And what I'm looking at on our patient here is she looks like she has a left posterior or left short leg to start with. So on a count of 3, we'll have our patient sit up. 1, 2, 3. And you'll notice I didn't really pull on the legs. She can prop herself up on her hands so that the legs relax. That's one important thing. If she contracts any muscles in this position, it could give you a false positive. Now if I look at her malleoli again, we can see that the left side actually gives the appearance that it got longer. So we're going to start with the assumption right away that she has a left posterior ilium. But we can also do a test that Professor Vleming actually used to use, or I shouldn't say used to use, that used in a very long literature study that he did on sacroiliac joint instability. Now these are the ones that have to be surgically corrected, but we can use that test here as well. So we're going to have our patient go supine one more time, and what she's going to do is now actively raise the leg one at a time. And we'll start with the right. And what we're looking for is either the patient has dysfunction, difficulty getting that leg up, or she may feel pain raising that leg up. And now on the left side. Okay. So in this instance, we'll just say that the patient had pain raising up the left leg. Now, we assumed from our supine to sit that this is a posterior rotated ilium on the left side, and on the right side it's going to be an anterior rotated ilium. So we can do a forced closure to see if the forced closure, in other words, correcting that rotation, improves the active straight leg raise in the supine position. So what I'm going to do is with my one hand, I'm going to get to the PSIS, and with my opposite hand, I'm going to be on the ASIS, and I'm going to give a gentle pull so that we recorrect into a neutral position again. And now we'll have our patient raise the leg up. And again, what we're looking for is it's easier to raise the leg up, or we have decreased pain associated with it. If the patient actually is telling you, no, it wasn't any different, you should always check the opposite side, because as what I said before, maybe we had a muscular contraction that gave us a false positive, or there's always the potential, which we should get in our history, is have they had surgery, has there been fractures, things along those lines that actually may give you a difference on the supine to sit test. Now, from here, I always go to a weight bearing, because in all honesty, sacroiliac joints are going to be more of a weight bearing joint. So we're going to bring our patient to a standing position. Stand right here. Now, sacroiliac joints also tend to hurt associated with lumbar spine range of motion, especially in a weight bearing position. So we can have our patient go through motions. We'll do flexion, have the patient bend forward, see if there's any pain associated with that, have her come back. We'll go into extension. We'll go into side flexion on both sides, and we'll do rotation. Now, in this demonstration, we'll just say the patient had pain on extension and the patient had pain on left lateral flexion, just as an example. So the weight-bearing force closure is going to be very similar to what we did supine. We're going to have the PSIS with one hand, so the hand that you can't see is going to be on the PSIS in the back. My right hand is actually going to be on the ASIS, and what we're going to do is a force closure is not push this way. We're going to do almost that semicircular pattern, helping the SI joint in its rotation. And then what we have the patient do is reproduce the painful ranges. So in this case, we'll say it was extension and side flexion. And what you should notice is that the patient's range of motion improves before the pain comes on, or it is pain-free, or they just notice that it's a lot easier. It's always amusing when you see one of your patients say, the pain's exactly the same, but they get an extra 20 degrees of motion than they did prior. So again, we're looking for improved range of motion before pain starts, or a complete decrease in the pain in itself. So this is a simple examination that we can do associated with sacroiliac joint dysfunction that's outside of the normal training that we see in many of our schools, using a combination of supine to sit. Now that's Diane Lee's work. I learned it mostly from physical therapists that I've worked with for years, as well as Professor Vleming, Andre Vleming's work associated with his 7-step examination that he does for SI instability. We use one of those tests, which is the active straight leg raise, and force closures while you're doing the active straight leg raise. This is Dr. Gregory Doerr for Functional Soft Tissue for April's condition of the month of sacroiliac joint rotation laxities.